Today's webinar on co-occurring intellectual developmental disability and behavioral health diagnosis 101 training. I'm Heike Johns, Learning and Development Coordinator for the Division of Developmental Disabilities, and I'll be your host for today's webinar. I'll begin with a few housekeeping items. Participants are muted upon entry. However, we do suggest that you mute your line as well. Also, you have the ability to control your viewing of the presentation via the navigation tools on the top right of your screen. If you have questions regarding the content being presented today, we ask that you use the Q&A box for those questions. If you have questions that are technically related, sound and such, please use the chat box. Listeners will be answering questions during the webinar as time allows, but please know any questions submitted will be compiled and responded to in a follow-up technical assistance and guidance document. This event, the presentation, and the recording of the webinar will be posted on the DMH website at a later date. It's notifying individuals that the information has been posted, as well as links to the information will be sent in the upcoming week. For today's webinar, there will be a brief survey open in your current window. We encourage you to please participate in the survey, as your feedback is important to us. And I'll turn over to today's presenters. Lucas, Central Area Behavior Analyst for the Division of Developmental Disabilities, and Amy Stevens with the Division of Behavioral Health, who is the Chief of Children's Community Operations for the Western Region.
Thank you, Heike. Amy, could you do a turn real quick just to make sure we can hear your voice?
Hi, Lee. Good morning. Can you hear me? Lucas?
I'm getting told by the lovely host Heike that the voice came through clear. I cannot hear it, but I'm going to assume that everything's working fine.
Thank you. Good morning.
So let's go ahead and get started. So if you want to switch to the next slide, Heike, please. As Heike was saying, this is a one-on-one training. We're just trying to introduce participants to some of these things related to people who have co-occurring diagnoses of intellectual and developmental disabilities and mental health concerns. So first off, we want to talk about just some common knowledge between the two areas. So common knowledge about IDD, common knowledge about mental health conditions. And they also need to talk about some common understanding of what people need. So needs associated with people with IDD, needs associated with people who have mental health conditions, and then, you know, the needs that they kind of have as a virtue of having both conditions. I also want to talk about what it's like to have a co-occurring diagnosis, what impacts a person's life. And then we also want to cover various systems on both sides, specifically how those sides can collaborate with each other. So what is disability? So it's an umbrella term. It could include a full disability or deficit, as well as an intellectual or cognitive disability. It's something that occurs before the person is 22 years old, and it's something that lasts their entire life. Specifically, intellectual disabilities is a deficit or a significant limitation in one or more of different areas of a person's life. So it could be in their intellectual functioning, it could be adaptive skills, so the ability to kind of adapt to new environments. It could be a limit or regarding to self-care, so their ability to change clothes, to take a bathe, some activity of daily living. Could be a deficit or a limitation in the person's ability to communicate. So they may struggle to communicate vocally through spoken word, and they struggle to use other forms of communication as well. Impact their ability to utilize the community in a typical fashion. Impact their ability to live independently in their own home. So to take care of those typical things you would have to take care of living on your own. It impacts their ability to work, impacts their ability to kind of self-direct their life. It could be impact in the area of being able to have relationships with people or talk or communicate and socialize. And it may impact health and safety skills that a person might have. Just to kind of bring the point home about this being an umbrella term, we have a Venn diagram here that is kind of messy, but I really think hits home that all of these different things come together to make intellectual development disability. So you have active behaviors, you have physical abilities, you have intellectual functioning, and you have intellectual disabilities. Intellectual disabilities could encompass or all of those sorts of limitations. So it might be a limitation or deficit in intellectual function, might be a limitation in the ability to perform adaptive behaviors. There might be a physical limitation, but it doesn't necessarily have to be there. So we're talking about a really broad category. I want people to understand that is a very broad category, and so we'll be talking about some typical aspects associated with intellectual development disabilities, but it's by far not the only aspects associated. So let's talk a little bit about prevalence rates. Some of the folks that have an intellectual disability are in the mild range, and just some typical facts or things about that range. So these are folks that probably have no unusual physical characteristics. They might be slower to develop, tend to attain the typical life milestones, to blend in socially pretty well without really anybody kind of being able to pick out that they have an intellectual disability, and they're able to pretty much normally function in daily life. That are in the moderate range, so these are folks with IQs of 30, 50, and we'll talk a little bit about that not being super important as far as determining somebody with an intellectual disability. But these are folks that have noticeable delays, so these are significant delays, specifically in speech, that will let you know that there's something that is going on, as well as they might have unusual physical characteristics, so something that looks a little bit different than typical. Probably have very simple communication skills, health and safety skills, need help with some tasks of daily living and self-care, but they can be independent in the community when they're in familiar places. Now, folks are considered to have severe intellectual disabilities, encompass of about 3 to 4% of folks in the community, and these are folks that have significant delays. They're probably late to walk. They probably have limited expressive communication, so they're very limited in their ability to communicate their wants and needs to others. They typically require a lot of assistance with daily routines, probably need some supervision. They're able to do less complex tasks of daily living and self-care, so they can take care of themselves, but they might need some support to do that. They probably also need assistance with socializing and social skills. They are able to do that with assistance. And finally, people with profound intellectual disability, and this is only about 1 to 2% of folks with ID, have significant delays in all areas of life. Certainly have congenital abnormalities, so these are physical abnormalities present from birth. They probably need pretty close supervision, need specialized care throughout their day, and they need intensive support to be able to kind of take care of themselves and do those activities of daily living. So a huge area. Primarily what we're going to focus on today as we talk about folks with co-occurring are those individuals that are in the mild range, at 84 to 86% of folks with ID. So let's switch gears and talk about mental health conditions. Amy was going to do this one, and if not, I can.
Yeah, well, so now we'll switch gears a bit and look at what a mental health condition, a big definition of that would be. So mental health conditions, kind of as an overview, broad definition, they affect a person's thinking, feeling, or mood. We could say and or mood. Could be all of the above or just be affected in one of those areas. It can be episodic, so that means that they could have more acute symptoms or more strong symptoms at certain times of their lives than others. And it can also be chronic and lifelong. And I think the most important bullet on this slide here is that when we think mental health conditions, we think about recovery being possible, and we're going to discuss recovery in more detail further in today's training. Slide, please. Look at some examples of most common categories of conditions and symptoms that somebody might experience. So some signs and symptoms that are most common across the board for mental health conditions. Of course, these categories aren't all inclusive, so there are some things that we're not addressing here. But some of the most common signs are changes in behavior. So change from a person's typical behavior. Maybe they're more impulsive, they're struggling to focus on things that they can normally focus on, or maybe hyper-focused, so they're focusing on one thing to the exclusion of all others, responding to things that aren't there. And we might see a decline, for example, in hygiene or their ability to take care of themselves, passive daily living sort of things. We can do an activity level. So either a more, frenetic kind of flustered sort of activity level, or we could see some lethargy. So that person just struggling to get up, to get going. They've just really decreased in activity. I guess I touched on this, and you'll notice that a lot of these are common in both sides of the house that we're talking about. But so communication difficulties, so maybe disorganized speech. The person is struggling to relay their thoughts and feelings to other people effectively. Change in appetite, so maybe their appetite is greatly decreased, and they're having trouble, getting themselves to eat. Maybe it's increased, and they're eating way more than they normally would. This could include cravings, binges, all kinds of different changes to appetite. Changes, of course, gamut from sleeping enough to sleeping too much. Kind of a change in what would be typical for that person. Changes in the time that they're sleeping, unable to stay asleep. Another sign is mood, irritability, activity level, a sense of hopelessness. And then we have increased sensitivity, so a heightened sensitivity to our different senses, a heightened sensitivity to maybe the texture of our clothes or the brightness of the room or a background noise that others are able to kind of filter out, but this person might be more sensitive to that sound in that moment. Next slide, please. And when we talk about mental health conditions, one of the things that we're looking at is both duration and intensity. And so just to give a general definition of those two ideas, the duration of symptoms or signs is how long those have lasted. So I've been experiencing this for a day, for 2 weeks, for a month, for the past year. And then intensity is going to be how strongly a person is experiencing the symptoms currently. And so a lot of times what a clinician will do is compare that behavior to the person's baseline. So, maybe I typically sleep through the night. I get at least 6 hours of night, but right now I can't stay asleep for more than an hour. It'd be pretty high intensity for that person. Or, I typically struggle to get out of bed every day. That's something that is a sign that I'm experiencing mental health conditions. But right now, I'm able to get out of bed every day. I'm able to function and go about my daily tasks and my job. So maybe I'm having lower intensity of that particular symptom at that time. I think the things that's important to consider here is that symptoms can fluctuate. It can be affected by different things like the life stage a person is in. And of course, we all know that our life stage affects all of us. Whether a child, an adolescent, a young adult transitioning to adulthood, an adult, an older adult, there are changes that come with that life stage, and there's a transition period as we move from one life stage to the other that affects all people. So it makes sense that it would also affect signs and symptoms of a mental health condition. Also significant to notice that variance between different people. So if two people have the same diagnosis, it's not necessarily going to look the same in both of those people. And because not a regular pattern we can follow, it can be difficult to predict when symptoms and functioning will change. And the other point on the slide that I don't want to miss is that a person with a mental health condition is going to impact their functioning in more than one area of their life, not just specific settings. So not just when I'm in this one meeting in the afternoon, but across different areas of my life I might be affected. So in this slide, we're going to talk about how changes in our environment can create behaviors, can cause us to show behaviors that mimic symptoms of a mental health condition. So kind of the classic example here is the death in a family. So a loved one in my family were to die, I would feel very sad, and I would feel sad maybe for quite a while. I might have trouble sleeping, might have trouble eating, and all of those behaviors mimic some of the signs and symptoms and health conditions that we just discussed. However, in this instant, for me, what they may be showing is that I'm a person grieving instead of that I'm a person with necessarily a mental health condition. And then to that is the idea that if a person is in an environment where they're missing out, Lucas talked about the importance of connection already, but where a person is missing out on those positive relationships, where their life isn't enriched with activities that engage their mind, they maybe don't have a setting that promotes a healthy lifestyle, their behaviors, a person in that kind of environment can also show behaviors that mimic symptoms of mental health conditions. So, an example, when it's a person living in a group setting or an institutional setting, and they lack maybe personal relationships, they lack privacy, they have minimal choice over what they do with their day, we see some behaviors that look like mental health conditions, but really could be a direct result of that environment. Next slide. The idea is the idea of stressors. We all experience stressors, and these stressors can change the way we think about the world. They can change the way we relate with others. They can change how we feel. So you know that today in the Kansas City area, it's storming rain, thunder, lightning, storming down rain, and that was a little stressful this morning, getting out the door and getting everybody to where they needed to be. And it changed the way I felt a bit this morning. It maybe made me a little bit more rushed and hurried as I tried to get my daughter to wrap her trumpet in a plastic bag. It changed the way I related with her and interacted with her. We all experiences stressors from time to time. And my storm example is a minimal one, but even things like moving from one home to the other, where we can experience a high level of stress and anxiety for the duration of that move. One of the differences, though, is that stressors that change the way we think and relate and feel, they're short-term impact. So they're while that once I got everybody where they needed to be in the storm, I stopped being stressed about the storm. Once we're settled in the new home and the move's behind us, that stress and anxiety goes away. However, it's when we see the impact of those stressful situations linger longer. So maybe 3 months later, we're still feeling that stress. Maybe stress is so severe that it's interfering with our day-to-day functioning. That's when we might consider it as a sign of a mental health condition.
All right, thank you, Amy. So what we want to talk about today is kind of this intersection between mental health conditions and intellectual disability. So again, we have Venn diagrams, and we really want to focus on that overlap area, that area in between. Are to compare how AD and mental health conditions affect the person, and we compare the systems that serve people on either side. And then with that information, we want to develop an integrative approach to assessing folks, assessing needs, and then coming up with an actual treatment or intervention plan, which leads to the procurement of services that they need. So just a little bit about prevalence. And this is just simply to give us an idea of kind of the scale of the population in which we're referring to. So if you look at the total U.S. population, there's a little over 300 million folks. At about a little bit more than 1.5% of the total population has an intellectual disability, so that's a little over 5 million people. And there's some statistics out there that say that around a third of the folks also have a mental health condition, which amounts to about 1.7 million people. And it's so important to recognize that as many as half of children who have an intellectual disability also have a co-occurring mental condition. compare that to a rate of about 8% of what we would consider neurotypical. So these are kids that don't have intellectual disability, have mental health concerns. So you can see that the rate of co-occurrence is a lot higher, and folks have the children with IDD. That's the total U.S. population. So on the next slide, those same sorts of statistics and applying them to state level. So we're making the assumption that the breakdown is relatively same as it on the national stage. So in Missouri, we have approximately 6 million people. So again, using those same statistics, about 100,000 folks in Missouri have an intellectual developmental disability, which is us an estimate of about a little over 30,000 people that have intellectual disability and a co-occurring mental health condition. So that's a large group of folks that we're talking about. And the next thing that's really important to note when you're talking about service systems, so not just DD, not just behavioral health, but both divisions, so both the Division of Developmental Disabilities and the Division of Behavioral Health, are moving from a medical model to a person-centered approach. And so what this means is in the past, the medical model, or what's sometimes referred to as kind of the expert model or the traditional model, the individual really is kind of placed in a passive role. So the training is kind of done to them, not with them, where in a person-centered model, the individual has a really active role in their care. So again, they're not just receiving treatment, they're partnered in just the treatment is, and also in the treatment process. In the medical model, or the standard model, or the expert model, the providing the service is the one making all the decisions. Moving towards the provider being a collaborator, so working with the individual and deciding what's best for that person. So is able to voice and make some decisions regarding what their treatment looks like. The model is really focused on and curing a disease. The person-centered model is really looking at how can we increase a person's quality of life. So one of the things we'll talk about in a little bit is a person who has an intellectual disability is someone that has a lifelong situation, and so we're trying to increase their quality of life. We're not going to cure their intellectual disability, so it makes more sense to bolster supports and skills for that person and increase their quality of life. Model, the provider is the one doing most of the talking. It may be that the treatment meetings or the team meetings may not even have the individual involved. So the person who is the recipient of service isn't even actively at the table talking with the planning team or the treatment team about what they want in their care. In the person-centered model, the provider is the one listening while the person is the one talking. They're the one leading the discussion regarding what's best for their treatment. The team, all the experts together and come up with this treatment package for the person, and they can either do it or not. But they're in it. And so in a person-centered role, they have had an active role in coming up with what their treatment looks like, and they have more motivation to kind of adhere to it and have a lot more buy-in into doing what's best for them as they've kind of voiced.
Likewise, we're also going to compare across the systems the concept of support versus recovery. So in the developmental disability system, services are considered to be time unlimited, so across the lifespan with that individual. And in the health system, they're time limited because they're when a person needs them, so they're as needed. A person may need more support and more services at certain times of lives, and then there may be other times when they really don't need that same level of support or services. In the DD system, we have support across the lifespan, as we said, and comprehensive support, which is really what Lucas just described to a certain level, so kind of across the across different arenas and areas of that person's life. And also DD side, I'm going to stick with the DD side here, there might be less involvement of credentialed professionals. So there might be less involvement of individuals such as psychiatrists, LPCs, LCSWs, for example. So to go back over to the mental health side and continue with that, not only are the system is set up to be as needed, It's also recovery and resiliency oriented. So we're going to talk about resiliency a bit more here in a bit, but recovery is really the process of change by which an individual improves their health and wellness, by which an individual lives a self-directed life, and by which individuals strive to reach their full potential. So an individual's recovery is defined by that individual, person-centered, as Lucas was talking about. They would define what their full potential looks like, what their recovery looks like. Our health system is going to focus on the impact of symptoms, how we can decrease negative symptoms, how we can increase things that are helping the individual and positive in that individual's life. And you might see in the mental health system more professionals involved at different times in an individual's life. So that's psychiatry, LPC, LCSW, you might see those more engaged in that person's system of care.
So we also want to talk about some common misconceptions that we hear frequently out there regarding both sides of the aisle, so both from Division of Behavioral Health and Division of DD. The common misconception is that DBH, Division of Health, only offers medication. So that's not true. So DBH has a variety of different treatment options that they provide, medication management being just a small piece of what they can provide. That another misconception is that people with developmental or intellectual disability cannot benefit from psychotherapy because they don't have enough verbal skills or they don't have enough cognitive abilities. This is also not true. Psychotherapy has been successfully adapted for folks with intellectual and developmental disabilities. Another common misconception is that the challenging behavior is because of the mental health condition. Not true. There's probably a relationship between the two, but it's not necessarily the case that the behavior comes from the mental health condition. On the opposite side, there's also a conception that challenging behavior is because of the developmental disability. Again, there may be a relationship between the two, probably in the area of skills deficit and some stuff that we're going to talk about in a minute as far as environmental challenges, but the behavior doesn't come from the developmental disability. Misconception is that there has a primary diagnosis, and that's going to determine what lead system or agency is. That's not true. So both systems collaborate together. The lead is determined based on the need, not necessarily the diagnosis. Another misconception is that services can't be provided by both systems at the same time because of quote-unquote double dipping. Also not true. Both sides offer different services, and services are used for different reasons. It's possible to get services from both sides simultaneously. In fact, it's a really good idea. Also, I mentioned that the Division of DD or the IDD system provides treatments for all the problems that could affect a person. Also not true. Not set up to provide treatment for folks with health conditions necessarily, which is why it's necessary to access services from the other side, which is why we're here talking today, because it's very important that we collaborate between each other. What can we get from each other? What are the good things on either side that we're already doing that kind of inform how we can kind of move forward and collaborate? So just a quick review, some issues that would be identified for an individual who has IDD or who has a mental health condition. So again, who has an intellectual developmental disability, this is something that they've had before adulthood, so prior to 21st year. Whereas with a mental health condition, they may that may appear for them at any time throughout their lifespan. So after their 21st year, so it could appear or reappear at any time during their life. For people with intellectual and developmental disabilities, typically have lower than average intellectual functioning. Notice on the other side, with an individual with a mental health condition, while their condition is active or when it appears, it could also impact their intellectual functioning. So again, have very similar issues across both sides. A person with intellectual and developmental disabilities will have intellectual or developmental disability throughout their entire life. That doesn't mean there's nothing that we can do about it. It just means that they have an intellectual disability and they will continue to have one. As somebody with a mental health condition may only have one episode, or they may have a lot of episodes. And again, it could be episodic, it could be chronic. What we usually do for folks that have an intellectual disability is we teach skills and compensate for the limitations that they have, which is part of what is done on the mental health sides, where Amy talked about recovery and minimizing what, as she said, the negative symptoms and building up those things that are positive in the person's life. So the treatment that usually involves teaching skills and compensating for limitations that are related to that mental health condition. Somebody who has an intellectual development disability, it's highly likely that impacts their ability to relate to people or have social contact with folks, which again, very common on the other side. So whenever symptoms are occurring, somebody with a mental health condition, it probably impacts their social competence or their ability to have relationships with people. So a lot of commonalities between the two. So think about when we're doing an assessment from the viewpoint of both sides. So on the IDD side, we want how that affects the person. Talked a little bit earlier about all those areas that could be impacted as far as skills for an individual. We assess that. We need to assess language. We need to assess their social skills. We need to assess their ability to care for themselves, so those activities of daily living. We need to assess their ability to problem solve, decision-making skills, safety skills, and we need to understand that some improvement is likely with appropriate intervention and treatment, but the level of impairment, the intellectual and developmental disability, will not change. So what we do is we want to teach skills that lead towards the individual having as much independence as possible, and we're going to focus on training and education and assistance for them in their daily life. So mental health side, again, we're assessing level of skills in the person's life area. So as Amy was talking about, is these things can be impacted when an individual is mental health condition. So their language may be impacted. Their ability to relate socially or socialize with people may be impacted. Their ability to care for themselves, take in the morning and dress themselves, feed themselves may be impacted. They may not be thinking clearly, so they might not be able to problem solve very well. They may have trouble making decisions. They might not be able to have safety skills. Is that the assumption is, once the mental health condition kind of subsides or recovery occurs, that you would have an improvement in these areas. So these aren't forever limitations, only limitations associated with like an episode of the mental health condition. So this is involved for folks on the health side would be individual or group therapy and potentially the use of medication. So you should consider to try to rate both sides when starting on the IDD system. Be thinking about what's the emotional impact on this person of this problem situation. So we don't think about that. We don't think about how the person might feel living in the situation that they're in. And we need to try to determine if the current functional level and problems are changed. So is this something that's been their basic level of functioning? Is it the same, or is it a change from normal? If a change of normal for the person, then we probably should be seeking out a mental health professional to see if there might be a mental health condition there. And then we should be thinking about protective factors and resiliency skills that a person might have. That's another thing we typically don't think about on the IDD side. We don't think about what might be protective for the person. We don't think about what makes them more resilient to those common everyday stressors that, Amy talked about a little bit earlier. So each prompt and kind of promote or reinforce those skills of doing things like waiting. This is a frequent problem for a lot of people, and one we don't recognize that it is a learned skill. So it actually takes practice teaching to learn how to wait for something to occur. You're born knowing how to wait. To teach somebody how to talk about their feelings. We may need to teach them how to identify what feelings they're actually feeling. We may have to teach somebody how to express anger in a way that doesn't also involve using physical aggression. We need to teach people how to say positive things about themselves, so like increase their self-esteem. Might need to help them learn to say positive things about their current situation, so kind of helping them with their outlook on their daily life. Those are things we should think about if we're starting from the IDD system. If we're starting from the mental health system or the behavioral health system, it's important to recognize that an interview with the person is likely not going to give you enough information, and it's probably not reliable information, so you're going to have to incorporate additional sources of information. So one interview is not going to be enough. You probably input on the symptoms and the effect that these symptoms have on the person from people around them. So you're going to want to involve a larger group of people. And the same sort of determination you're making from the IDD system is you're trying to determine if this current functional level, so what they're presenting as, is a change from what their typical or what their baseline is. So if it's their typical functioning, and that might lead you to want to get in contact with the IDD system because it may not necessarily be a mental health condition that you're looking at. So those are things to think about when you're doing an assessment for an individual. Next slide, please. This lovely graphic, I love it. Just kind of visualizes what we're kind of talking about here. So the reason why I love this graphic is because it's messy. It really reflects kind of what life is. And so you notice in the middle, so the problems are the gaps. So what does that mean? So above you have those typical environmental demands that any person might have. These are all those things that are external to us that causes us trouble in day-to-day life. So you have like stressors, you have settings that may or may not be conducive to a person doing well. You have a person's ability to vocalize and realize their dreams, their desires, their goals. You have external supports that may or may not be present. You have, activities that are interesting and meaningful for the person. So that's the person's environment. And then on the bottom you have the person's personal competence. So this is going to be those skills that they have to meet their basic needs, or to be independent, or remain healthy, or what their physical health actually is. This is going to be things like their learning history or what they've experienced through their life. So this might be things related to trauma or skills that they've had an opportunity to learn or maybe haven't had an opportunity to learn. This be their IQ score. It'd be what resilience and protective factors they have in place for them that help them manage those environmental demands. And so the problem is the gap, so the mismatch between what their environment and what their personal competence is. So decide, no matter where we're starting from, so whether we're starting from the IDD side or the behavioral health side, we want to know how the person's competence, their personal competence, matches with their environment. So we figure out what is missing. We need to figure out what might make the person more able to meet the demands. We need to look at what the demands are. There's a difference between a person not being able to manage a situation when the demands are unrealistic or over the top or more extreme than any typical person would be able to deal with. That's a problem with the environment. That's in somebody not being able to manage typical environmental stressors that we would all do. So an example was a fantastic one about this morning in the thunderstorm. That's a typical stressor that a typical person would typically experience in day-to-day life. So if the issue is that the person's not able to manage, they don't have the personal competence to deal with that typical life experience, that's an opportunity to start addressing some skills with the individual. So again, thinking about what can we change in the environment? So how can we make the environment more conducive to support that person? We may involve modifying demands and expectations that meet the person where they are, or that bring down to a level that would be considered positive and non-coercive, increasing their ability to access interesting and meaningful experiences. Also thinking about what we can bolster or improve or increase in the individual. So what can we teach them? Can we teach them resiliency skills? Can we build those up if they're already present and make them even stronger? What protective factors are there? Can we build those up? Can we make those stronger? So those are things we need to think about in order to kind of start narrowing that gap. So it is, and I've kind of danced around it a little bit, but it's not about the person's diagnosis. So the thing about diagnosis is it's probably a starting spot. It's related to probably the dumb. It's probably necessary for funding, and it may be helpful for a psychiatrist to think about what the diagnosis is in order to narrow down some medications that he or she might select. But it's not enough. It's just a start. It's just the surface of the issue. This is with the person's individual situation. It's not going to give a close enough look at needs of close enough look at what the person specifically and uniquely needs to be successful in their life. Zooming in on the problem behavior or the symptom specifically is also probably too narrow and not helpful overall. So we need to look at the person as a whole. So to look at how all these things interact with the person's life to figure out what do they truly need. So it's not just diagnosis, it's not just their behavior, it's not just their symptom, it's how do all of those things come together and interact with other areas of a person's life to help kind of come to an understanding of what this person really needs to be successful. One of the things that we often overlook, so this is an important area of need when it comes to supporting anybody, but specifically folks that have co-occurring intellectual disabilities and mental health conditions, is that social support is incredibly important. Social support to use the strategies that we're teaching. So not only that the person's learning these strategies, but that there is social support and living situation in their day-to-day life that actually supports the use of those strategies, that has the skills to nurture and proactively respond to an individual with a challenging situation, to continue the work that's being done in the treatment session out into the person's everyday life. And one of the things we also need to think about is one of the things we also need to think about is what does success look like for that person. So think about all those situations in which the person lives on a day-to-day basis and what success looks like in each one of those settings. So what do they need to be able to do when they're out at the store? What do they need to be able to do when they're home alone? And what does success look like? So how do we know that they're actually being successful in that situation? And coming up with a measurement of success that's individualized for that person. So knowing that everybody should be able to do this, we're looking at what does this person need, what is this person able to do, what can we teach them, and figure out an individualized measure of success. So whether to create what we called an integrative treatment plan. So this is the integrative model. So we need to figure out what the gap is. So this is identifying all those needs that the person has. Needs based off something in the environment or needs based off skills deficit for the person. And the treatment plan that we come up with that's integrated is going to tell us what, when, where, who, and how of what's going to happen. So we need to know what the need is. We need to identify what it is. We identify what we're going to do. So we know what the need is. We know what we're going to do. We need to know when we're going to do that. So is this something we do all the time? Is it something that we're going to be doing when the person's out on a shopping trip? Is this something we do when they're at home? Is this something we do when they're at a job? We need to know who's going to do it. Is this something that the person's going to work on themselves? Is this something that the parents or family are going to work on? Is it something that direct care staff that work with the individual are going to be responsible for doing? And then finally, the most important piece is how do they do it? So it's not to say that we're going to support the individual every time they're at work, and staff are going to do that. How are they specifically supposed to support them when they're at work? We need step-by-step instructions. And this whole treatment plan is to try to ensure that we are creating this supportive environment, that we're motivating people, including the person, to continue to participate in treatment, that we're teaching skills to start addressing those personal competence issues, and that we're completely those environmental needs that we've identified when we assess the gap. just to help make this practical for you all, things that you should be thinking about depending on what side you're on. So in the IDD system, you should really consider seeking mental health professional assistance if you are working with an individual who has a mental health concern. You should, if starting from the DD side, be looking to get consent from the individual and the guardian to participate with the behavioral health provider, either in a treatment session or to at least have communication with a therapist. That way we have an idea of what they're working on, so we can help kind of facilitate the continuation of that approach in the daily life through direct care or through other supports that we're accessing. Also to make sure that our approaches from DD system providers aren't in conflict with what's being done on the behavioral health side. We should really consider what stressors or situations that are occurring in daily life that might exacerbate the symptoms, so might make the symptoms worse, and to avoid those if possible, and if not possible, to minimize their effect. We definitely need to recognize that a behavioral health or mental health condition can be episodic, which means it could come and go, so we may need to restart behavioral health treatment over the lifetime of the person. So just because they have a condition diagnosed, had some treatment, seemed like it was successful, and they no longer have behavioral health services, but now all of a sudden they're having the same sort of problems again, we may need to start behavioral health services again. So it may be a service we access frequently or every so often. And then we also need to regularly review all of the supports the person has to make sure that these are what the person really needs. And mental health system, we would consider seeking out a person who's a professional on the IDD side that can offer assistance related to intellectual and developmental disabilities. We have to adapt to what treatment modality or treatment method that we're using to be more successful in working with folks who have developmental disabilities. And this might include breaking down the skills that we would teach in session. We might need to break down the concepts. So do what we would call a task analysis, so a step-by-step of what the skill is and how it's taught. We might need to frequently review and increase repetition of the teaching. So it may take a little bit longer to teach. We may have to concrete example from the person's life and not use a lot of metaphor or abstract examples with the individual. And we might even need to use pictures or very simple text if we're using written material. So just breaking it down so that we're presenting at a level that the person could receive it and be able to utilize it. We need to seek out support persons to carry out the same strategies or similar strategies in the person's home, so where they're living, so that direct care staff kind of have an idea of what's being worked on in therapy so that they can facilitate that and continue it ongoing. So they don't necessarily need to know everything that's being discussed in session, but if you're working on, say, coping skills or tolerating distress, direct staff or the person takers, could be family, need to know about that as well, because they need to be able to recognize when it's happening so they can notice and reinforce it. They also need to help the person be able to practice and use it when they need it. Probably going to require a longer course of therapy, or you might need to do it in shorter sessions. So say a typical course, and I'm just making this up, is 15 sessions over the course of a couple months. So for this individual that you're providing services for, let's say sessions are typically an hour. Well, maybe 30-minute sessions is going to be more appropriate over 30 sessions. That might be what you have to do in order to kind of adapt it to be successful with an individual with intellectual and developmental disabilities. And we always, and this is true on both sides, need to consider what fundamental needs of a person is for quality of life. So again, talked about a little bit earlier, there's a lot of environmental conditions that can mimic behavioral health conditions or mental health conditions. So not having a meaningful day, not having any relationships, not having basic needs being met can result in a situation that a person behaves in a way that makes you think that they have a mental health condition, when in reality they just need some fundamental quality of life stuff met.
All of the things that Lucas just went over and talked about, the integrative model and different things to consider when we're working with individuals in this population, all of those things can be impacted and affected by the person's possible experience of trauma. And so it's important that we spend some time talking about trauma, and so that we're able to recognize it and to consider it in this population, just as it's important to consider it in all other populations that we're working with. First off, what is trauma? Trauma is a traumatic event, is where a person experiences, witnesses, or is in some way confronted with actual or threatened death, serious injury, threat, actual sexual violation, threat in some way to their physical integrity of themselves or of someone else. And oftentimes, a trauma response, or the way a person will respond to trauma, is with intense fear, a sense of helplessness, or horror. And so trauma really depends on a person's perspective. Only that person can judge if an event was traumatic for them, or if an event was a trauma event for them, or if it wasn't. And so I think we can all think about natural disasters that maybe we've experienced or we've heard about. Individuals can go through similar experiences with that natural disaster. And one person may experience that event as a trauma, and another person may not. So it really depends on that person's unique and individualized perspective. Trauma, I think it's important to talk about that it can be both a private or a public experience. So, for example, private events that might be trauma include things like sexual violation, physical abuse, domestic violence. So events typically leave a person feeling powerless, hopeless, isolated. And then public events, that can be things like I mentioned, the natural disaster or a war or accident. All those are still traumatic. They can still represent trauma in a person's life. They are also shared experiences. They typically don't come with the same kind of judgment attached that some of the private events can come with. And so people may be likely to feel helpless or isolated. But again, it's an individual experience, and it really matters. The person's individual perspective really matters in how they experience that event. And this is, I think, really key for this population. Again, this is going across the board and working with all the people that we work with. So trauma can be acute. Talk about it as being either acute or chronic. So an acute trauma would be a single traumatic event that's limited in time. So a car accident, a school shooting, a natural disaster, sudden loss of a loved one. It's something that happened. It was limited in time, and it was just a really violent or sudden or serious event. Or sometimes people will say complex trauma is the experience of multiple traumatic events that can be all varied or can be the same. So this could be someone maybe who's experienced long-standing or ongoing abuse or neglect, or somebody who's living in a war environment and it's long-standing, it goes on for quite a while. And there's a cumulative effect. So one single isolated event for that person may not have been experienced by trauma, but the ongoing events, the ongoing experiences have a cumulative effect to create the experience of trauma. So the other important take here for trauma, and I think I started with this, but is that it can have a large impact on a person's life. And not only a large or significant impact, but across different areas of that person's life. So, you know, a person may experience nightmares or flashbacks. They have hypervigilance, so they're overly reactive to maybe sounds or noises, or if someone touches them unexpectedly, they could have a strong startle response or a big reaction. It can be sometimes avoidance, withdrawal, impulsive behaviors, somatic complaints, so physical complaints, so headaches or stomach aches or all kinds of different physical ailments that can be experienced. So trauma is definitely very impactful across a person's life. Next slide, please. Thank you. To talk about trauma, we then need to talk about resilience. So first off, what is resilience? It's a word that we see thrown around a lot, and I think sometimes we use it in different ways. But a kind of an umbrella definition, it's the process of adapting well in the face of adversity, of trauma, of tragedy, of threat, or significant stress. I mean, in kind of a layman's way of saying it, it's bouncing back or able to bounce back from difficult experiences. So one of the things that a lot of things Lucas was talking about is helping a person, assisting a person in building resilience. Resilience is something that we can build, that we can foster. So some of these ways are to help a person find a sense of their purpose in their life, to give them meaningful activity, a sense of who they are and where they fit in this world, to positive beliefs in their abilities, that there are tasks they can accomplish, that they can see things through from start to finish. And this third one, I think this is kind of a thread through this entire training, is that strong social network. The connection to other people is key just in so many areas, that a person can embrace change, optimistic, so see some positive, even sometimes in difficult situations. It's hard for all of us at times, and so, if we can help people to see that, as long as it's done with empathy and understanding and sensitivity, that can be key. Nurturing yourself. So we talk a lot about self-care, but, the ability, helping a person learn how to take care of themselves in the same way that we would take care of a loved one if they needed it. So to provide that nurturance. Being problem-solving skills and establishing goals, and goals, as Lucas was saying, that are meaningful to that individual and not directed from others. And next slide, more about what it looks like when a person is emotionally resilient. So emotionally resilient, you might see that having the ability to wait for what's right instead of acting on what they want to do right now. So instead of acting impulsively or maybe aggressively, instead of punching that wall, instead of yelling, they're able to wait, to pause, and wait until they're more certain or sure of a healthy or appropriate way to act. They're able to sit with discomfort. So I think this is a key one. There are a lot of difficult situations in our lives that can, as we've been talking about, that can make us feel sad, that can make us feel stressed, that can be very scary. And an emotionally resilient person would have an ability to sit with that discomfort, to experience it, to say, and I'm just really sad right now, or that's really, really frightening, and I still feel really shaky because of that, and to sit with that and to experience it. And that comes with that feeling will fade. So you have to have kind of a hope or a confidence in that. To be able to get perspective situation, especially if it was an isolated situation, to understand that you are safe now, for example, or to understand, for example, that it was an isolated moment in time, to practice acceptance. So, to be able to accept some circumstances that are less than what we want. So maybe the death or the loss of a pet, to be able to accept that, and to be able to be sad about that and to grieve that, but to have some acceptance. To remember the power of time. May not heal all things, but that time can change how we feel and how we respond to things. And we feel acutely sad and, strongly grieving in the moment, but that with time, that will dissipate and we will feel happy again and confident again. That it's okay to have all the answers immediately in the moment, and of course to engage in self-care. So that's kind of a picture of what emotional resiliency works on. I think it's interesting to, as we read over these, to think about how these are things that we all struggle with and we all work to build throughout our lifespan. So it's definitely not something that's limited to just this population. We talk about protective factors, which goes hand in hand with resiliency. So I like to think of it as like a force field almost for a person, I guess maybe Star Wars or Star Trek, kind of that force field up sort of thing. So use protective factors. We want to help people build these protective factors so that when bad things happen, they have a bit of a force field around them so that they're able to practice some resiliency. And so the protective factors on this slide come from the Strengthening Families approach. So really what these protective factors are is, in this example, enhancing parental resilience. So the parent's ability to respond in the way that I just described when bad things happen relating to their child's life. Again, providing an array of social connections. Social connection and connection to other people is one of the strongest protective factors across the board. Providing parents concrete support in times of need. You know, here's a number for that. Let's call this person. You want to sit in the office and make that call, something concrete. You know, friends and family might say, hey, listen, I'm bringing dinner over to you at 6 o'clock. You know, that kind of concrete support when somebody's going through a difficult time. And then these last two are facilitating knowledge of not only parenting and child development, but also in this population, knowledge of IDD and mental health. So understanding of what's going on can help a person feel a little less out of control, and can help a person maybe know what to expect and maybe know how to respond. So that knowledge is really key to having a sense of mastery over some difficult situations.
Jump in for just a second.
Yeah, please do.
I just want to talk about, so this is for the strengthening families approach, but it equally applies for an individual that's an adult who has direct care staff that support him in his or her home. So millions of not just parents for children, but also staff members of an individual that's supported in a residential setting. And one thing that we've talked about a lot today is the importance of social connections, but I really want to bring home the point that we're talking about unsocial connections. So we're talking about people having social connections with other people that aren't paid to be there with them. So it's important that an individual has a relationship with the people that are employed to support them, but that's not enough. We're talking about beyond that. We're talking about having friends outside of the people that are paid to support them. We're talking about joining social clubs or churches or library groups. We're talking about being a part of the community, not just being with people that are paid to be around you 24 hours a day.
So on the next slide, I'm going to read a paragraph about how it might look like or what it might be to experience living with a co-occurring diagnosis. So again, remember, this is kind of an umbrella experience of what this might be like. So I'm going to read this and first person as if a person with a co-occurring diagnosis were speaking this. So we're vulnerable. I know I am different and can't do what others my age have achieved. I'm dependent on parents and caregivers. I am constantly snapping at people I care about and don't know why. I have problems trusting people, and people have problems trusting me. If I live in a facility, I may have endless people coming and going in my life. I have limited receptive and expressive language and may not be able to tell what's real or not. My make sense of my world can sometimes be impaired. My sense of self-esteem can be more fragile. And yet I long for what every human being longs for, to be loved and accepted, to have friends, to have a purpose in my life, to feel safe and secure, to have some say or choice in my own life. I may have a co-occurring diagnosis, but I have the same kinds of feelings and emotions that all human beings experience. It is mobility that makes me more prone to be a victim. And unfortunately, the abuse that is often inflicted on people like me is inflicted by the very people that I depend on for my daily care. So, of course, all those things are not true for all individuals who have co-occurring diagnoses, but they're common experiences and common feelings, and I think it's important for us to keep in mind what that experience can be like to live with a co-occurring diagnosis. What this slide shows, again, is what experience looks like and how it's really linked together. And I think we've talked a lot about that, about the connections and sometimes the circular connections. And I think it's important, and all have a strength perspective, and there's a lot of strength in this population too. But I think it's important that we consider these areas where a person with co-occurring diagnosis may have some challenges, because these are the areas that we can maybe, when our systems work together, create the most impact for these people. So that's difficulty with relationships. We've talked a lot about that. Loneliness, increased activity in social environments, difficulty focusing, problem solving, access to quality life that is person-centered and where they have some choice and some privacy, a vulnerability to mental health concerns, and then possibly a lack of direction, life direction, which goes back to having that sense of purpose that we discussed earlier.
So a little bit about what social impact may be present. So an individual with a co-occurring diagnosis might and probably does feel different than their peers. And so as Amy read that kind of vignette of the individual's experience, they recognize that there's differences. And those differences contribute to them feeling isolated. They might feel rejected. They probably have a low social status. People probably avoid them because they do odd things. And so as a product of that, they have trouble developing and maintaining healthy relationships. They want, just like everybody else wants, to have healthy and meaningful and positive and loving relationships, but people treat them differently, and they might have the skills yet to be able to accomplish that. They have might experience some limited social value in interacting with their family, definitely with their community. So lack of access to things, lack of inclusion. So just overall, social value in their overall life. Probably dependent on others for things that they need or for ways to be happy, to get access to meaningful or positive experience. So if you think about an individual residential setting that has direct care staff that are hired to assist them all along, especially an individual who has a co-occurring diagnosis and probably has some pretty significant challenging behavior, a lot of their access to the things that they want for their needs and also for their happiness is delivered through staff. So they're dependent on other people for everything that they might need, just to be happy, but also just to meet basic needs. They depend on other people for their life direction. So a lot of times there's an issue with treatments or individual support plans or just general directions of treatment or life course being decided by people, not the person. So they're not having a lot of input on what their life could look like or what they want it to look like and what direction they're moving. Don't have a lot of options. So instead of saying what we'd like to do, they're saying here's what we're going to do. Nobody looks to them for help. You know, they probably feel and recognize that they are the one that always asking for help from somebody else, and nobody ever depends on them. Which again contributes to being feeling rejected or feeling like they are at a lower social status or they're isolated. Nobody looks to them to make their day better. Again, feeling like it's a one-way street, so always asking for something but never being able to give in return. An area is cognitive impact. So Amy kind of went through those typical challenges that people experience, and so one of those things might be they have trouble focusing on things. So they have a shortened attention span. So their ability to kind of maintain focus on one specific activity may be a little bit shorter than a typical person. They might have trouble understanding an abstract concept. It may take them a little bit longer to kind of get the gist of what's being explained. They might struggle with problem solving, so they need additional time. They need additional support to solve complex problems, which means that they probably need frequent repetition or a little bit extra time to be able to work through situations. Can't, it just means they might need a little bit of extra time and support to be able to do that. A lot of times, though, they experience very low expectations of themselves, and then other people have also very low expectations of what they're able to do. This, again, contributes to being isolated and feeling like you're at a lower social status because nobody expects much from you, and so you've come to not expect much for yourself, and so that really limits all that potential that you would have if you had the adequate supports, and so that contributes to limited ability to learn skills that are necessary to help the person meet their needs. So not a lot of learning has happened. And what skills are present are probably pretty basic.
One of the key reasons why a training like this is so important and why further trainings are so important in our work with this population crucial is because of their vulnerable population. So this population is vulnerable to abuse, neglect, and trauma. Many individuals with developmental disabilities, with mental health conditions, with co-occurring diagnoses experience maltreatment, which includes physical abuse, sexual abuse, or neglect. It's common for this population to have negative interactions with law enforcement. There can be a decreased or lower resiliency, and we already talked about that. So you could imagine with this increased vulnerability why there might also be the experience of low resiliency. Protective factors might be limited, and support system might either be limited or kind of stressed so that they're less effective at all times. This population can also be more vulnerable to health concerns and health conditions. And really, what the research and things bears out is that people with developmental disabilities, and especially those who have some challenging behaviors, either because of one of their diagnoses or because of environmental issues or stressors, that they're really exposed at a greater frequency than the larger population to serious human rights violations. So our work with this population is very key and very important. Next slide, please. We talk about that direction of life and that giving the life meaning. And so one way of accomplishing that is by goals that are person-centered, that are directed by that person. They're meaningful for that person. We're not telling that person you need to get an A in that class if that's not something that's meaningful for that person. They are part of the process of setting those goals to the extent that they're able to be. And the goals also reflect their different stages of life. So, we acknowledge the fact that goals need to be somewhat different for a young child than they would for an adult. They need to be somewhat different based on the individual set of circumstances, the individual's functioning, the individual's specific environmental circumstances at any given time. So goals need to be reflective, and I think part of that is that they need to be kind of living and breathing and change as the person changes and goes through different stages of life.
Things that we probably all have experienced if we have supported individuals with co-occurring diagnoses in the past is that a outcome for these individuals is that they end up at the hospital. So let's take a little bit and talk through what might happen in the person's life that might make going to the hospital work for them. Or what I mean by that is make going to the hospital kind of beneficial to them or meeting a need that they have. A lot of times when you look at these situations, the person say they're having a psychotic episode, quote unquote, but when you really dig down to it, you find out that they haven't had a lot of access to positive interactions. So, for example, the person goes to the hospital because the nurses are really nice and they talk to them. There's a cute doctor that interacts with the individual, and they really like that sort of attention. And so it gives them an ability to meet the need of having positive interactions with folks. They don't have that in their house. They don't have that in their day-to-day life. Believe it or not, going to the hospital might give them the ability to choose what they want to eat. Hospital, depending on what your experience with hospital is, you may not think they have good food, but when you get to choose what you can eat, including things like pudding and ice cream, they make going to the hospital a good thing because that's where I get to pick what I'm going to actually eat. Too interesting and patients when you go to the hospital. So you get all kinds of great drugs that people give you that make you feel differently and maybe help you kind of manage through a troubling situation, and you don't have access to that at your regular house. Be shelter, so you don't. It's a safe place to go, so you don't feel safe in your home, or like that you don't have a place to live, so you're out on the street, and so you go to the hospital. And it's a safe place to be. It's a place to get out of the it's a place to be safe from somebody who's hurting you. There might be familiar people there. So if you think about an individual who lives in a residential agency and direct care staff turn over frequently, and they may not even know who's supporting them tonight, but go down to the hospital and they know the doctor there by first name because they've been there so often, so they know where people are familiar. Or they may go there because there are interesting things going on. So they know who the new doctor in charge is. They want to know who the new nurse is. They want to see all the other patients that are admitted. So it's an interesting experience. So it's entertaining. They may have a lot of access to interesting and meaningful activities. They may go to the hospital because it's less stimulating than their current living situation. So it makes more sense for the hospital because they don't have such a demanding situation and there's activities going on that they actually like to do. So, for example, interesting groups they can go be a part of. They can watch TV with their at the hospital. Maybe sometimes, depending on what hospital you go to, they might have outings that they go on with people that are admitted. And so these things are much more interesting than what they got going on at their house. And so those are some reasons that kind of motivate somebody, or might kind of put a situation where going to the hospital actually is beneficial for the person. So how do we help? So typically in this next section, we would group out and we would go through the two scenarios, one for a child and one for an adult, and kind of come up with a basic treatment plan. That's going to be really difficult in this current format. So what I thought that we would do is I'll have Amy go over the case situation for Karina, who's a child example. We'll kind of read through it, and then we can talk a little bit about some demands that we might notice, and some skill deficits that we might notice, and just kind of talk through a little bit between Amy and I. And people are welcome to also provide input through the Q&A box, and try to get a little bit interactive, but it's going to be kind of hard since we're doing it in several locations. Is that okay with you, Amy?
It's sorry, I couldn't find my unmute button.
No worries. Okay, so Amy will start us off with Karina, which is the example, and then I'll follow up with Carl, who's our adult example.
Let me let know a little bit about Karina. So Karina is 12 years old, with an intact family and one sibling, her brother, who is 9. So Karina fights often with her brother and has recently hit, scratched, and thrown a glass of water at him. The brother is typical of functioning. He plays baseball and basketball, and was recently recognized at school for being outstanding in math for his grade. He lives in a large Midwest city, and Karina attends middle school in her neighborhood. She is in special education classes for reading, for math, social studies, and science, and regular education for homeroom and PE. She's been tested and found to be in the mild functional range, and currently in jeopardy of failing the 5th grade because she's been able to keep up with math and social studies and her homework, and has failed the past 4 weeks of weekly quizzes. So she reports she has some friends at school. Right now she's mad at her best friend because the friend's hanging out with other girls and likes them more. And the teacher says she avoids the other kids and that they don't prefer to play with her because she's bossy and demanding, and she makes up stories about herself and her accomplishments. She's even gotten into some fist fights at school. Development is unremarkable other than typical milestones like walking occurred in the later range of normal. So, for example, she walked at 17 months. She frequently has headaches, especially in school. Medical causes have been ruled out, and the doctor says that the headaches are likely psychosomatic. Other medical issues mentioned, other than nightmares and occasional nighttime urinary accidents. Parents are seeking assistance. The family is experiencing increased stress and unhappiness as a result of the frequent fighting between their children. The parents are arguing more, and Karina's issues with her schoolwork. Karina's upset and previously would have cried and thrown herself to the floor when she was required to do homework or when she was required to play nice or follow rules. She's begun now to lash out verbally with her brothers and peers at school, and physically when things don't go her way and when she's forced to do something. The parents are worried she may be autistic or mentally disturbed or depressed. They feel she can often do the tasks required at home or school, but that she's lazy or belligerent on purpose, and that she's jealous of her brother. These probably gotten worse since the start of the school, and the parents want some help in how to get Karina to get along better with others, be more compliant at home and school. Karina has stopped trying to fit in at school and is not pleasant or fun to be around at home. So that's Karina. I can recognize in Karina a lot of views that some of us may work with. So, we're going to look at some of the gaps, for that gap slide that Lucas talked about, between her environments and her personal competence. So demands and expectations in her home. So we're following the demand and expectation at home to follow rules, to get with her brother. Demands and expectations at school are to pass these weekly quizzes, to pass the 5th grade, to be able to sit quietly in class, to act with children in a way that makes everyone feel comfortable, the children and teachers included. And then social situations, expected of her, that she not be bossy or demanding, that she not make up stories about herself, that not yell or lash out or be physically aggressive. Lucas, are there any demands or expectations that you think I'm missing there?
Yeah, so those are great, and what I would add is also I think, and this is probably across situations, is the kind of comparison that gets drawn between Karina and her younger brother. So that expectation that she should be able to do as much, if not more, than her younger brother, because she's 12 and he's 9, and he's excelling in areas that she struggles with.
I thought it was key in this vignette that, you know, right now we're seeing an escalation of behaviors, and at the same time, her brother's in a place where he's being rewarded on the sports
Right.
side and also being recognized at school for outstanding in math, and then Karina's struggling to pass her weekly quizzes. And so, right, I mean, the timing of that and the stress of that is understandable.
And another thing that I thought was really important to consider, and cue to your slide on talking about trauma and how that can manifest sometimes is complaints, is here's a child who has headaches all the time for no apparent medical reason, has nightmares at night, and is sometimes having urinary accidents. This is a 12-year-old. So I wonder if she's experienced trauma, and so that would probably be something to think about as well.
Absolutely. And so, so I think going down to the what's missing on the skills and support, and you could probably spend the next hour looking at some of the things, but, you know, from I think across the spectrum in home and school and social situations, what's missing is consideration of how we could do some environmental adaptations versus expecting her to adjust and adapt to all these different environments in a way that is considered normal or is considered tolerable by the people around her.
And also, you know, the parents seem to indicate that this is a skill problem for Karina, that it's a motivation issue, that she knows what to do, she just doesn't want to. But we can't hear that that's accurate. We would look at to make sure that these skills that people are assuming that Karina has, she does possess. So just because she is 12 and whatever grade that she's in doesn't mean that she has the skills to meet the demands that are placed upon her in that grade from an academic. Just because she's expected to take care of her chores or whatever at home, can't assume because she's 12 she knows how to actually do that. And so there may be an opportunity to recognize that she actually has some skills deficits in these areas, and that some of this behavior is related to trying to avoid having to do something she doesn't know how to do.
Yeah, and along with that is the skill to have some like tolerance, or to be able to tolerate some negative emotion. You know, when you don't feel happy, when you feel frustrated about a task, to help her build that skill to be able to tolerate that negative feeling, maybe even to be able to communicate it to those around her, to seek help, you know, some positive kind of coping strategies. That right now she's gone from throwing herself on the floor to now, you know, starting to act out in more physical ways. So, yeah, I think that's definitely a skill that's missing there. And then, you know, school-wise, I think when we look at youth, that school piece is so important, because she's failed the past 4 weeks of her weekly quiz. So we can see kind of the ripple effect of how that can affect her self-esteem, how that can affect her mental life, how that can affect how she perceives her brother's successes. So, you know, that's just such a key area in the life of children. And so we can help, as you were saying, Lucas, build skills so that she can experience some success in that setting.
Awesome. Thank you. So let's move on to the adult example. And again, this isn't to be interactive with everybody, and so I noticed there were some questions during that section, and there's one that we will answer in a second when we get through the adult one related to the individual's due process rights. And so, Emily, if you can hang on to that question for a second, and we'll get to it once we get through this. Very much related to your question, Emily, we want to just cover this real quick before we talk about the adult example, is that we want to, again, talk about the quote-unquote hospital seeking that a lot of folks have. Carl, the guy that we're going to be talking about, attempting to attend the hospital or actually getting to the hospital to be admitted. So these are some things he might do to do that. So he might describe hallucinations that he's having. So people are voices or somebody's telling him to do something that he doesn't want to do, and those people aren't actually there. He might describe or seem to experience what we would call delusional thinking or paranoia, so thinking people are out to get him or having beliefs that are very grandiose and not know that they could be true. He may engage in physical aggression to hurt others, or he may hurt himself. So say he's going to kill himself. So these are all things that people might do to get to the hospital. Let's switch and talk about the people. I would like you guys to think about that as I go through this example. So Carl, 4-year-old young man, he grew up in and out of foster care systems, so he's had lots of placements. His mother also is at the borderline to mild level of intellectual functioning. In the home environment, there was alcoholism and abuse by the father, so the father had a lot of issues as well. The child was frequently removed from the home because of abuse and failure to protect, so he's been bounced around the foster care system. He's been in and out of his own home. He tested and he functions at the mild level of intellectual functioning, so in that group that we talked about where 85% of the folks are. He can read at the second grade level, he can do some simple math, and he has an elementary level of understanding of history and civil rights. He's been ill for the last 3 months because he's made threats and he's destroyed property at his residential care facility in which he was living. To blame others for being mad at him or treating him unfairly, and he's to anger and makes outlandish threats towards others for revenge when angered. He wants to live on his own, not in a group home. He has not had a job for more than a few weeks at a time, and he gets mad when a boss tells him what to do. He can be very engaging and fun to talk to, and people often like to talk to him a lot, at least until he lashes out at them, and then he turns to burn his bridges. Many quote-unquote men hobbies. He likes to fish and hunt and hang out, but he doesn't currently have any real peer groups. He doesn't really have any friends. He likes to do all these things, but he doesn't have anybody to do them with. He carries a diagnosis of borderline intellectual functioning, intermittent explosive disorder, child ADHD, bipolar disorder, and borderline personality disorders, which have varied in combination depending on the treatment environment. Lots of diagnoses that may or may not be different depending on where he's at. He has over 15 psych hospitalizations in the past 2 years, and he frequently calls 911 and tells the operator he has just taken pills, cut himself, beat somebody up, basically anything that he can say to get people to respond. Asked if he's suicidal, he says, "Yep, I am." He has engaged in cutting on his legs, but he's never required stitches or any formal medical treatment. Police have been involved many times, and they have taken him to the hospital after a 911 call or because he's threatened staff or others at the group home. And in 5 different homes during the past years, Patron is currently in the hospital. He has charges pending for threatening staff and vandalizing 2 staff cars. The prosecuting attorney and judge have agreed that a jail sentence would not be in his best interest or in the best interest of society, and are requiring that he be sentenced to probation and mandatory counseling. They want his anger control issues addressed, and they want to be able to function with the oversight available to him through a community mental health center and a probation officer. They would like for him to be in a very structured, secure setting. So Carl has a lot of demands across his areas of life. So from basically home and work, it seems like he is very sensitive to any kind of direction that somebody is giving him. Might be related to a history of being abused, and so he's probably very sensitive to what I would call coercion. Probably also is true in situations he's had. So he's very sensitive to people disagreeing with him. He has some skills, may struggle to do the things that are required to have a job, which may also contribute to his inability to keep a job for a long period of time. It seems like he some being met by going to the hospital, and it seems like his reaction to a demand or an expectation that he's not really comfortable with or doesn't agree with that in the home is to attempt to gain access to the hospital. It seems a huge mismatch between what he expects and what is true in his social situation. So he really wants friends. He likes doing a lot of what he calls men things, and he has nobody to do them with. And so really things that might be missing for him is some basic social skills, able to start a conversation, to keep a conversation going, the ability to tolerate and say something that's uncomfortable, the ability to express anger in a way that doesn't involve physical aggression or threats of harm or actual harm itself would be also really important, I think. What do you think?
Yeah, I think too. We discussed trauma, and we look at his history of an environment of alcoholism and abuse by his father, and was removed frequently due to abuse and failure to protect. So I think another thing that's missing is kind of the consideration of trauma and how that's affecting his kind of across the board, and in particularly probably how it's affecting his ability to connect with others.
Right.
So I think that's another kind of key thing that affects all three of these areas: homework and social situations. Right.
And if you think about it, where was he most likely to go when he was yanked out of the home for abuse? Probably to the hospital. So if you think about his life, he likely associates a hospital as a place of safety, and he also probably is very sensitive to any sort of coercive or demand from people, because in his past those have been closely associated with physical abuse. So people start raising their voice. I know from my past, from Carl's perspective, is that I'm probably going to get beat up or something bad is going to happen to me.
Right.
And I want to get away from that.
Absolutely. And I think, too, there's a consideration of loneliness and how this plays into it, because it all kind of feeds together. And then 24 years old. So, if we look at kind of lifespan and where he is, that's that transition age where you're going from what's considered an adolescent or youth into this adult life. And so that could be a frightening transition for someone like Carl, who's not had the benefit necessarily of always having that supportive childhood and those kind of safety net structures of friends and family, and transitioning from being an adolescent, being a youth, to being an adult. So I think the hospital provides some of that structure that is missing in his now adult life.
Right. Something we would want to set up is a very loving and positive environment that he could exist in, that's got probably pretty low demands to start with, and very empathetic staff, and then the ability to access places where he could start to develop some actual unpaid supports, and then some intensive treatment, definitely for what is going to be some horrific traumatic experiences in his life, learning some of those skills so that he can start to bridge that he has between his personal competence and his environment. That is for Carl. There was one question kind of related to an adult and hospitals that I will read here, and we will kind of discuss. This comes from Emily, and it says, do you have any suggestions for getting the hospital to accept and agree with the client's due process terms? Adult client that engages in behavior because she can go to the hospital to obtain access to the telephone, use the telephone to randomly dial numbers to try to obtain sex. The hospital will not restrict her access to the phone because she's over the age of 18 and it is her legal right. So suggestions for that. So I have some questions, and you're more than welcome to jump in. The first that occurs to me is why so if going to access a number to help with people to have sex, could be unnerving and troubling because you want people to be safe. That's my question: is the best possible course of action to just lock down her access to the ability to have an adult sexual relationship with somebody? It's more of an how do we teach this person to have a safe relationship and meet people in a way that's typical for a person's age, and recognize that she's just like everybody else and has wants and needs, That's probably a more fruitful to consider than trying to get the hospital to lock down her access to the phone. What do you think, Amy?
Yeah, I agree. And I think, I think it also kind of goes to some person-centered and to having some control in her life and things like that. So I think there's maybe some skill building there, and there's some, to kind of look at what needs are being met through that activity with her, and is this a normal part of the lifespan she's in, and something that we need to help her build skills to do in a safe way, or is it something that's related to a background of trauma or something where there's another need that's going met, so she's meet that need. So I think that there can be a lot going on with that, and I'm sure there's much more to that story and that scenario than we know at this time. Yep. But I think it's of utmost importance that we give people as much that people have the freedom to access to a phone, and that they're able to, especially in the adult system, that they're able to make calls and make those communications and connections. So your question, though, is a question of safety. So I think it's definitely complex.
Yeah, I think you hit it really, really good on the head, Amy, that it really requires just a really close look at what's the need here, what's the need that's not being met. So, for this person in her past, who's probably had trauma, is sex related to feeling close to somebody because that's how she was abused, and is it something that we help her kind of develop some skills and develop some close relationships that aren't based on sex? Is it she just wants to have a relationship with a person, and maybe we can teach her a way to build and grow and have an adult relationship with a person in a way that's socially acceptable and doesn't require going to the hospital. So it really goes back to what's the need that she's trying to meet by going to the hospital and utilizing the phone. So I'm going to go ahead and summarize because we're 7 minutes over. Just kind of close out, I want to with a few reminders. So the important here and what we tried to kind of show throughout our presentation today is that collaboration, cooperation, and communication as a team. So this is not the IDD team or the behavioral health team, but is this the entire team and across both systems is incredibly important to be able to develop integrated treatment plans for a person to help them have their needs met and kind of close the gap. And that we need to have a common understanding of the needs across both systems to help the person with all areas of need. And then we all need to know the impacts of to live with a co-occurring diagnosis, and we need to understand the systems in which people are exposed to. So the behavioral health system and the individual in the Division of Developmental Disabilities system. So tried to convey. Hopefully we succeeded with that. I want to also go ahead and thank everybody for attending today. I would like to thank Jeff for being an awesome host, running all the technical stuff and being amazing. I would also like to give a humongous thank you to Amy for jumping in at the last moment and just blasted out of the park with a fantastic job presenting this information. She did phenomenal. This talk would have not been anywhere near as good without her here, so I'm great appreciative of that. You guys' comments throughout, and there will be a survey that will pop up here in a minute that, if you are willing, would be amazing if you could try to provide some feedback about this so that we can make this experience better and better each time we do it. And as Heike mentioned at the beginning, the recording of this presentation, the slides, and also the technical assistant document, if there's anything that we need to cover that we haven't gotten to yet, will be available in a few short weeks on the division's website. So with that being said, I wish you all to your days, and thank you all for coming, and it was a pleasure to be able to talk with you.